First of all, thanks so much, everybody, for coming to talk today about our learning environment and how to create an inclusive learning environment. I see some new faces on here, and I'm going to try to manage the chat, but also invite you to unmute if there are challenges that you have with hearing me or with seeing my slides, or just want to comment. I'm Shanta Zimmer. I'm the Senior Associate Dean for Medical Education here at the CU School of Medicine, and I'm also formerly the Associate Dean for Diversity, Equity, and Inclusion. And I'm going to hop right in if I can share my screen. All of us are like, how long have we been working with Zoom? And it's still sometimes challenging. Here we go. Okay. Somebody give me a thumbs up that you're seeing the slides in the right view. Buddy.
It's in the presenter view.
Thank you. How about now?
Yep, it's good.
Okay, cool. Thanks so much. Thanks for playing. So whenever I talk about bias, I always get frustrated that I feel like we don't really have enough opportunity to talk about what to do about it. So I'm going to talk a little bit about bias, but also then spend some time talking about what we can do about it and what you can do about it. And I want to say thanks because I know a lot of you are already working on this with your students and in your environments that you control at the moment. So I also, everybody who's ever heard me talk knows that I always love to start with saying thank you. I want to say thank you to the people who introduced me to the importance of this in the learning environment, especially the residents in my former residency program at the University of Pittsburgh, Vivian Chitty, who was one of the only Black women in our entire program for a number of years, and then lots of other folks. I won't go through that whole list, but I do want to give a special shout out to my nephew, Sebastian, who in the lower right-hand corner is watching a video, a YouTube video of President Barack Obama. And he used to tell me, Sebastian told me, Tia Shanta, your president is a mulatto like me. Because Sebastian's parents are one from Mexico City. He's my husband's sister is from Mexico City, and his father's from Tanzania. And so in some ways, he was very right that he was, in his words, a mulatto like President Obama. I said, well, we don't really use that term here in the United States, Sebastian, anymore, but you're right. And it really hit me about the importance of representation and what it meant to him to be able to see somebody who looked like him in such an incredible leadership role. Sebastian is about 11 years old in this picture, but he's graduating from high school at the end of May and will be going to law school in Mexico in the fall. So maybe he will be like President Obama. I don't have any financial disclosures, but I do have biases. When I think about why is this important to me, what makes me motivated to think about bias and to think about inclusivity, and I have to reflect on my parents. So in the middle of the picture there, you see my mom and dad at their wedding in 1970, just 3 years after the Loving Act was passed. So if they had been married 3 or 4 years earlier, they wouldn't have been allowed to be legally married in the United States because the Loving Act is what allowed mixed race couples to be married. What I didn't know until I was much older, and they're getting ready to celebrate their 53rd wedding anniversary next month, is that they experienced a lot of racism and discrimination by being a mixed race couple. They would go to motels and hotels where there was a vacancy, and then all of a sudden they would walk in and there would be no vacancy anymore when the two of them came to the front desk. To this day, if they were to check into a hotel, my father would go first and check in and make sure everything was okay, and then go get his bride to check into the hotel. And that also just kind of speaks to the generational impact that discrimination can have, even in a relatively mild experience. The other reminder that I have about biases is to think about things from the perspective of joy and excellence. We spend a lot of time talking about in our society today what it means to be getting Starbucks while Black, or running while Black, driving while Black. And we focus on the negative experiences that these communities have, which is important. What we sometimes forget to do is also focus on the excellence that comes from diversity and also on Black joy. Some of you listened to the podcast Black Voices in Healthcare during the pandemic, part of the Nocturnus series. And one of those episodes was actually called Joy. And in that discussion, it really talked about the joy that comes from the culture, the uniqueness, the richness of that type of diversity. And the picture on the screen that reminds me of that is Stephanie Wagu, who's one of our graduates last year, who's an intern finishing up her internship in OBGYN at Johns Hopkins University. And Stephanie, in this picture to me, exemplifies Black joy. She had just finished her first session as the national president of the Student National Medical Association, a true leader and person who represented excellence in my view. So we not forget that. I hope we'll be able to clarify some definitions about stereotype threat, microaggressions, and bias, talk about strategies to create a brave environment. I'm really starting to like this shift from talking about a safe environment to a brave environment, because if things are safe, then they can sometimes be lack challenge or lack advocacy, and that's not what we want. We actually want to create brave spaces. I want to think about times in your curriculum where microaggressions are most likely to occur. So where are the places that we can watch out for? And let's brainstorm about ways to be an ally and upstander in the classroom and on the wards, and then reflect and strategize about fostering a culture of a growth mindset where there might be discordance between learner and teacher views of their identities, and how do we move past that? And then reflect on some individual programmatic and institutional interventions that we can do to improve the learning environment. This is a broad list of assignments, and I want to just share that some of us may be at different stages. Maybe you're saying like, ugh, I've heard all of this before, Shanta, not again with the bias talk, but maybe there's something towards the end where you say, I wonder if I could improve this learning environment, or I could do something in this particular area. So hopefully there'll be something for everybody to take from here. This is just a reminder about how unconscious bias or implicit bias gets into our brain. There's probably some neurologists on here, so I'm going to be embarrassed about my dumbing down of the neuroscience from this book by Daniel Kahneman. Many of you've read it. It's called Thinking Fast and Slow. Mr. Kahneman, Dr. Kahneman actually won the Nobel Prize in economics for his work on how we make decisions. And he really breaks the brain down into two very simplistically two areas: the system one, which is our fast thinking, or system two, which is the slower thinking. System one is where our implicit biases live. And that's the automatic type of thinking and decision making that we make. System two is where we often go when we're making a more serious decision and we have to be more thoughtful. Think about a challenging clinical case. System two will come into play, versus system one, where it might be a routine illness script that you see. The same thing happens as we interact with people. And many of you have taken the implicit association test, or the IAT, developed by Harvard researchers in a project called Project Implicit, which basically links dichotomously strong feelings one way or another about a particular image or identity. I show the image of an overweight person in the lower right-hand corner with the association between bad for overweight or good for thin, and what that strength looks like. So the IAT measures the strength of associations that exist in our brain. It does not measure whether or not we are biased or racist or homophobic or anti women in science, as one of those tests is. It measures the strength of our automatic associations in our brain, and for me gives warnings about where we need to slow down. On the lower left-hand side, you see an example of an association. This is an association that many of you probably have. I don't think there would be anybody on here who didn't recognize that symbol. But what would be hard for you to do with your fast brain is to tell me what that picture actually is. The first thing that you would say would be Starbucks, or maybe one of your favorite coffee beverages. What you wouldn't say is Greek goddess or green mermaid or any of the things that that image actually represents. That would require you to hop over to the slow part of your brain. As I think about de-biasing strategies, I think about moving things into my slower part of the brain to prevent me from making decisions that are based only on that association and not on the facts that are ahead of me. Examples of where associations come into play are everywhere. You can see in the upper right-hand corner a hooded Black teenager, and you can see my own son in a hoodie, and recognize immediately the difference between the associations that exist in our media for a Black teenager, Trayvon Martin in this case, who was murdered for carrying a bag of Skittles and a Mountain Dew, associated with danger, with gangs, with violence, as opposed to a teenager who maybe didn't look they had African American heritage and would be viewed differently. This is a reminder of the conversations that our colleagues who come from Black families have with their teenagers about what it means to be safe in their environment and what strategies they have to employ to mitigate the impact that biases have on their actual living environment, not just their learning environment. Another important concept related to associations is stereotype and stereotype threat. So in the upper left-hand corner, you see a cartoon, wow, you suck at math versus wow, girls suck at math. The stereotype that exists is that men or boys are better at mathematics than girls are. And that stereotype can be triggered or primed by asking people to identify their gender. So the study that is most salient around this is the one where you ask children to take a math test, write their name, and then take the math test. And then write the name, write their gender, and take the math test. And in the times that the girls are primed by having to write their gender before taking the exam, their scores are lower than the boys. If they don't have to be primed to write their gender first and invoke that stereotype threat, then there is no difference in the scoring of those tests. Unfortunately, that's been repeated over and over and over again. And even as we have more women in science and STEM, those differences in terms of stereotypes still exist. Other examples of stereotypes are things such as these. Women like me don't do neurosurgery. Women have more empathy. Overweight people are less likely to be on time. There are different types of stereotypes, and I really just want us to focus today on the stereotype threat, which is when people are aware of a negative stereotype about their social group, and then they experience anxiety that they might confirm the stereotype, undermining their performance. So the feeling that girls have that they might not be good at math because that's the stereotype creates anxiety that can lead to underperformance. There's a study done called the Yale Preschool Study looking at biases that teachers have in their preschools. And so what was done here is that they actually asked teachers, preschool teachers who did not know the children they were watching, to watch kids who were playing at a, like a coloring table. And you have a picture of what those children look like. And while the teachers were watching the video, there was an eye tracker on the machine that was watching where their eyes were going and which children they were watching at the table. None of the children were misbehaving, and the teachers were instructed to watch them for trouble. 42% of the time, the preschool teachers who did not know these children watched the Black boys at the coloring table, and 10% of the time they were watching the Black girls at the table. So there are some gender differences that were happening there, but there were also racial differences as they watched the Black boys 42% of the time and the white boys 34% of the time. For me as an educator in the school, what I think about is my students who come here, who represent these identities, what does it feel like for them to have been watched since preschool, quote unquote, for trouble? How does that impact their ability to engage in our curriculum in the classroom, especially when they may be one of a few, or as was the case several years ago, the only person who looked like them in the classroom? And fast forwarding to the wards, how does that impact learners on the wards when they may be the only person of their race or ethnicity and their gender on the wards? Let's see if this works to play this video here. I want to warn you that the video that I'm going to show you, if you haven't seen it before, and even if you have, can be really upsetting. It talks about the differences in children's perception of their own value based on their race.
In Brown versus Board of Education, the famous case that desegregated schools in the 1950s, Dr. Kenneth Clark conducted a doll test with Black children. He asked them to choose between a Black doll and a white doll. In most instances, the majority of the children preferred the white doll. I decided to reconduct this test as Dr. Clark to see how we've progressed since then. Can you show me the doll that you like best or that you'd like to play with? That one? And can you show me the doll that is the nice doll? And why is that the nice doll? She's white. And can you show me the doll that looks bad? Okay. And can you and why does that look bad?
Because it's black.
And why do you think that's a nice doll?
Because she's white.
And can you give me the doll that looks like you? "15 out of the 21 children preferred the white doll."
So one of the upsetting things about that video for me is the fact that it was done fairly recently, about 2007 or 8 now, and that it was a repeat of something that had been done, decades before. And the hesitation at the end, especially of the little girl who realizes that her labeling, it's almost like her brain is betraying her in her own knowledge about her values there. And I think about the impact that has, because those children who were in that video are around the age that they would be applying to medical school now. And what would it be like for them to be coming to medical school, having had that experience? It's just not that long ago. Some of you have seen this picture, this painting before. It was on display here right before the pandemic, when Norman Rockwell, right at the beginning of the pandemic, Norman Rockwell exhibit at the Denver Museum of Art. And what a lot of people hadn't noticed about the image before was the racial epithet that is scrawled on the back of this. And this is as Ruby Bridges is going to elementary school during desegregation. A lot of folks took advantage of that image and made this one, again, a reminder of what Sebastian taught me about the importance of representation, to say what it looks like to have somebody who looks like you in a leadership role. And to me, this speaks to the importance of having diversity in terms of our faculty and of our teachers for our medical students as well. So when are we susceptible to our biases? This is not comforting to anybody who works in academic medicine. It's when you're fatigued, when you have excess cognitive load, so more than one thing happening at once, when there are time constraints, when you have ambiguous or incomplete data, and there's some growing literature to suggest that burnout also contributes to our biases coming into the environment. Probably don't need to tell anybody about this, about why it matters in our teaching, mentoring, and patient care and hiring. The main reason for me is that disparities exist in every specialty in medicine. In order to address health disparities and improve the health of the communities that we serve, part of the mission of our curriculum, we need to recognize that those differences exist. The next one is that diverse populations produce better outcomes. So we know this happens in medicine, in science, in business, in education, and even in sports, that diversity improves the outcomes, whether that's the pay or the impact score or the patient outcomes. We also know that biases impact our decision-making, and we make dozens and dozens of decisions a day. I actually have a sticker on my desk that says, "Did you consider equity in this decision?" Just as a reminder to slow down for that. We also found that implicit biases contribute to poorer patient outcomes. And so that's another reason to address it. Unfortunately, it's just not enough to know that you have bias. Otherwise, we just take the IAT and we'll be done with it. But it's actually only a starting place for how to address this. And then I always like to include this quote from Dean Riley: "We aren't interested in diversity because it's the right thing to do." Parenthetically, it is the right thing to do. "We care about diversity because we are aspirational." And really, my goal for us as an institution is to move from a deficit perspective, where we check boxes to change the face of medicine, to a value-based or excellence-based perspective, where we're trying to do this because we want to be the absolute best, and we know that diversity is important for that. This is just a list of some of the examples of where racial disparities exist in the care of patients from diseases. Unless you think that your specialty is not impacted by this, I assure you that every specialty in medicine is, even when you control for all the things that we think to control for: level of education, socioeconomic status, access to insurance. There are still differences that exist in patient outcomes based on race alone. I try to figure out, where does implicit bias come into play in terms of patient care? How does this happen? And the best study I could find about this specifically was related to communication. So this is a meta-analysis that was published in 2017 that studied the impact of implicit bias based on the IAT in most cases, in most of the studies that were used, on outcomes. And what they found is that there were differences in treatment recommendations, expectations of a therapeutic bond between both the patient and also the doctor and the patient. in pain management and in empathy, and that communication is where things really broke down in terms of implicit bias contributing to racial disparities. This study is old now, from 2016, but the Ohio State University where this took place, Quinn Capers was the dean of admissions there, and he asked his admissions committee of about 200 people to take the IAT in preparation for their admissions committee season. 10% of the members of the committee reported in advance, I know that I'm going to have white preference. I know that that's where my brain will go. In actuality, 64% of the men and 52% of the women on the committee displayed implicit white preference when they took the IAT. And interestingly, the student members were not very different. And this is important to me as I think about educating our students as well, is that the students told Quinn, I'm glad you're making the faculty do this, but they were sure that they weren't going to have the same amount of bias. They had their highest recruitment season of underrepresented minorities in the history of the school that year, which would be remarkable in and of itself. But what's really impressive is that Ohio State has stayed a leader in this space and is recognized as a destination institution for people of color, particularly African-American physicians and students. I have some examples of how disparities exist in other specialties. So in plastic surgery, just really looking at the complexity of this, racial disparities have picked two different types of plastic surgeries. One is craniofacial surgery on the left-hand side. There are lower rates of physician referrals for face transplant. There's been a delay in consultation for craniosynostosis surgery, later interventions for cleft palate care, and higher complication rates for minority populations following cleft surgery, and an increased geographic distance to a higher level trauma center. So these are all things that contribute to the lower numbers to racial disparities in outcomes in craniofacial surgery. You're probably thinking to yourself, like, well, Shanta, some of these things are not implicit bias, and some of them are systems-based thing. And this is really speaking to what a difficult problem this is, one of those sticky problems. There are a few things that are related to bias. For example, lower rates of physician referral might be related to a bias around whether or not the patient would accept the referral. There needs to be interventions that are different based on the type of outcomes that we're looking at. Geographic distance, for example. But one of the things that can be helpful is to have members of that racial or ethnic group in the population of physicians who are caring for these patients to recognize and call out these differences. Similarly, if you look at post-mastectomy care and breast reconstruction, and this is a study done at Hopkins and Yale, you saw that national trends in utilization for different types of breast reconstruction varied based on race and ethnicity over time. And racial disparities in breast reconstruction, while they're improving, the differences still persist at this time. The causes are multifactorial, but they do include a lack of difference in the physicians who are caring for them. And there's been a call to address non-patient factors, because again, people tend to say, well, it's the patient population that was referred late, or Black women have present with bigger tumors, and so there may be differences there. So there's a lot of opportunity for education. It's not an easy problem. We can look at our own materials, so curricular materials. So this is a study looking at the types of curricular materials that are used as core training for plastic surgery. For example, if you look at the scale on the lower left-hand side, you see the Fitzpatrick scale from the Fitzpatrick dermatology book, and pale skin or Caucasian skin is type 1 to darker skin, type 5 and 6. And what they found was that in 1,800 photographs and 230 graphics, 82% of the photos and 97% of the graphics in the core required curriculum were only Fitzpatrick 1 and 2. So there were almost no images beyond that lighter skin tone. And then we wonder why there are biases in the outcomes for teaching of these students and residents. We looked at some bias. So Ty Loxweiser's team looked at bias in the grading of our clinical curriculum. And this is mostly based on the non-LIC curriculum, so the traditional block model curriculum. And what they found is that there were differences in the percentage of honors, high pass, and pass grades in every block when comparing underrepresented minorities. So minorities who are Latinx or identify as Black versus non-underrepresented minority students or majority white students. And what they found is that underrepresented students had fewer honors and high pass grades than the majority group students. When we adjusted for the shelf score, some of these differences were no longer significant, and we made some changes related to this to say we weren't going to emphasize the shelf score as often. We also found differences based on gender, and similar to the underrepresented students, what we found was that men had fewer honors and high pass grades than women. I want to pause there and say, how do you feel when you hear that we have underrepresented students having fewer honors versus how do you feel when I say we have men having fewer honors based on gender? I don't know if anybody's actually out there participating. I can see you guys. We push in a little further into some of the differences and where they might come from. So this is a study that was done in collaboration between Brown and UCSF. And what they looked at on the purple and green side of your screen is the words that were used in the narrative of the medicine clerkship for honors students at the top and passing students at the bottom, majority white students on the left by the purple side, and underrepresented students on the right. And they were able to find differences in the words that were used to describe. First, you see that there were a breadth of words that are used in the purple to mostly describe non-URM students, as opposed to ones that were described only for URM students, the green ones, a much smaller number for just those students. So the examples of the breadth of language that could be used or was found in the narratives was broader for the majority students. But up at the top, exceptional, lucky, exemplary, great, phenomenal, impressed. And then for the URM students, words were Spanish, pleasant, soft, cultural, nice, good. Some of the ones that were closer to pass for majority students were reliable, interesting, or sharp. Words matter a lot, and I know that those of you who sit on grading committees think about these words as they come through on the evaluations. The slide on the side of the right side, the figure on the right-hand side is gender. So on the left in the teal color is the words that are used predominantly to describe male students, and on the right in the peachy color is predominantly female students. For female students, wonderful, empathic, delightful, compassionate, efficient. For male students, deeper, active, relevant, great. There's been a lot of work looking at these words and what they mean and how we interpret them. And I encourage our grading committees to kind of think about this and these biases as they're looking at the language. And I know, for example, in psychiatry, they've done some work on de-identifying them and trying to really think about it from the perspective of, just what's being described as the action. As Ty always says, to describe verbs instead of adjectives to describe our students will help us get away from some of these biases. Since I gave some examples from surgery, I wanted to give this milestone evaluation example from emergency medicine as well. And what you can see here is if you look at resident performance across time, in the dark green color is PGY1s, dashed lines is men, and solid line is women. And what you see in the PGY1 is the distribution in those green is almost identical. So the distribution of people who were evaluated at the first level up to the fifth level, not very many PGY1s come in as a level 5 competency. You can see that they're pretty tight. So everybody comes in, men and women, around the same. The second set of bar graphs is actually the PGY 3-year. Again, solid yellow line is women, and the dotted line, dashed line is men. And what you see is a gap. So these lines are not perfectly lying on top of each other like they were for the PGY1s. Something happened to the women, or is there something that happens to our perception of them during their residency training program? In particular, you see a big gap at the number 4. So there were many more men who were rated at a number 4 in their competency at the PGY 3-year than the men. And what happened there, and why did that come into play? What is perceived as being important for women during that and men during that time frame as an emergency medicine resident? And I think about how does this translate to the way we evaluate our students in these different clerkships as well. Probably not surprisingly, people think, stereotypically that in surgery there will be some of these biases too. And this study published in 2021 actually shows that difference as well, that during the PGY 5-year, male trainees in surgery were frequently evaluated at higher overall milestone scores compared to the female trainees, similar to what we saw in emergency medicine. And this difference was in performance in medical knowledge between female and male trainees was associated with a difference in training time of up to 1.8 months. So imagine having to delay your fellowship training because you were held back through the perception that you might not be performing as well in your surgery clerkship. So with these data in mind, what can we do? So some things that can happen are, one, are efforts around diversity. First of all, diversity builds on diversity, not just matching racial diversity to attract more people from racial minorities, but actually all types of diversity improve the sense of belonging or the sense of acceptance that in the culture of the institution. So more women, some of the things that we see at first are that gender efforts come first at an institution, and then racial and ethnic minorities feel welcome because the gender efforts made improvements in equity. And then other marginalized groups like LGBTQ communities may feel more comfortable also being out, for example, in that community. You can also surround yourself with images that defy stereotypes. So look around your environment. What are the things that it looks like when you walk into the doctor's waiting area or in the hospital or in your teaching environment? Improve the circumstances of your decision making. So for us, that often means slowing down, having a sticky on your computer like I have, tabling some of your decisions to get input from others. Be mindful of your reactions. If you're having that, prickly feeling on the back of your neck, or you're feeling uncomfortable, think about, where is that coming from? Why am I feeling this way? Is there actually something that's happening? Or is that gut feeling something that I should be checking? And literally do a gut check to say, is this my bias, or is this actually something that's happening in the environment? Consider the other person's perspective. Even though we feel like our students have a lot of control over us by their evaluations, actually the person with the power in interactions with students is the faculty. We are the ones who have the power in those circumstances. So students will often be uncomfortable, maybe nervous, especially if they're talking about feedback or having a high stakes assessment. One thing that we do a lot in clinical medicine is we say, let me run this case by you. I had several episodes this weekend. I was on call and I talked to another colleague and said, hey, can I run this by you? What we don't do is run our educational experiences by one another, but there's a wealth of expertise here, especially in our model with the LICs and our directors and our content directors. So there's a lot of opportunity to ask for help. What do you think about this scenario? Can I run this situation by you? Be aware of your biases. Again, as I mentioned, it isn't enough just to know about your biases. You actually have to put strategies in place to mitigate the impact of them, but it is a helpful start. And then do what all of us do best, which is to learn people's stories. As soon as someone becomes a category other than their perceived identity, either visually or on paper, then they become a whole person. And the bias, the automatic thinking of our fast brain sort of falls apart. I had several patients this weekend. I loved learning their stories. 2 engineers, somebody who worked in the hotel laundry, a retired school teacher. As soon as people become those other identities and those stories, which is what we do so well in medicine, some of these biases can be mitigated. I'm going to pause quickly here and see if there are questions before I shift to addressing some of the microaggressions component, which might be what most of you came for today anyway. Any questions or comments? Anything that I showed so far? Feel free to type into the chat if you want to. I'm monitoring that as well. So I was just talking to the LCME steering committee before I hopped over here, and one of the things we were talking about was mistreatment, and the department chairs were asking, what we were doing to make it disappear. And I think that the truth is that we're never going to make the learning environment perfect, and things aren't going to disappear. But one of the things that is really helpful to our students, and actually to us and to one another as colleagues, is that addressing microaggressions will often make people feel heard and included, and can do a lot to decrease the impact that these have on the long-term mental health of students and colleagues. So I always say that addressing microaggressions requires moral courage, and that I don't always have it. This comes from a conversation I had at a national meeting where I was explaining a way that I had addressed a microaggression, and somebody in the audience raised their hand and said, I don't think you demonstrated enough moral courage in how you responded to that. I was frankly embarrassed and a little bit hurt that they would say that about me. But now I realize, upon reflection, feedback is love, right? Now I realize that they're right. Sometimes my moral courage isn't as strong as it is in other times. Sometimes I'm flying on one wing. Sometimes something has happened to me that makes me less courageous. And so what can I do to lean on others to help me stand up in some of those situations? I do know that when I speak up, I often feel better about having done so, and I bet the same is true for you. Just so that we're all on the same page, a microaggression is a subtle but offensive comment or action directed at a minority or other non-dominant group that is often unintentional or unconsciously reinforces a stereotype. Microaggressions are things such as, I don't see you as Black. There are categories and themes of racial microaggressions like alien in my own land, the myth of meritocracy, the idea that only the best person should get the job, for example, without a clear definition of what that is, or color blindness, that I don't see you as Black really means I don't see you as who you are as a whole person. The ascription of intelligence, often with biases in a positive light, but can be slights to others related to certain racial or ethnic groups. Here are some examples of those. You speak English really well to someone born and raised in the United States. Are you a nurse to a female resident examining a patient? Are you the sitter to a Black resident walking to a patient's room? You look too masculine to a self-identified lesbian resident. Minorities are so hung up on race to a fellow resident, or your people must be so proud of you to a resident with an accent. These were published in JAMA in 2016 in an article called My Name is Not Interpreter. Before I move into a striking example about the combination of stereotype threat and microaggression, I just wanted to do a reminder of what stereotype threat is. So this is an example of the adapted vulnerability scale. And here are some items that are listed in there in this scale. During clerkships, my evaluators expect me to do poorly because of my race or ethnicity. Clerkships may be easier for people of my race or ethnicity. Some people feel I have less medical ability because of my race or ethnicity. On clerkships, people of my ethnicity often face biased evaluations from others. In medical school, I feel that others look down on me because of my race or ethnicity. So these stereotypes could exist within the person of that particular race or ethnicity, and that can feed into the way microaggressions impact them. So the next slide is one that I have permission to share. It's a text message that I received. I apologize for the fact that it's an upsetting one, but I think it's really important for me to share how this particular text message taught me about the intersection between stereotype threat and microaggression. So this is a microaggression. Medical student texted me, gave me permission to share this. I got called the N-word by a patient today, first day, great. This was after emerging from the pandemic and stepping onto the wards where she was the only Black student on the wards, but also the only person of color on the team or in the hospital that day when this happened at the bedside of a patient. Until that text message and the next time I gave a talk about stereotype threat, I had not really realized how microaggressions come together with stereotype threat. And I've really adopted this circle A, B, and C as a motivation for me to be an upstander. So in circle A, a situational cue that makes salient the stereotype. So remember those stereotypes I just shared with you. People of my race, as a Black woman, I'm less likely to be evaluated highly. I may not be accepted. I'm not part of the team. So those are stereotypes that may exist, and the person could have stereotype threat. Receives a microaggression from the patient in this situation. We don't have control over that. Those two combine in circle A and lead to circle B, where internal physiologic mechanisms take place. Anxiety, negative cognition, a physiological arousal, reduced performance expectation, reduced effort, reduced self-control, and actual reduced working memory capacity could occur in that moment. In this situation, the student said to me, I sweated through my white coat, my heart was beating out of my chest. I knew that I wasn't any good anymore. All of those things happened to her in this moment. And then comes circle C. In the long-term consequences of impaired performance, discounting the importance or validity of feedback. She even said to me, my attending said I did a good job on my presentation, but I know he just said that because of what happened with that patient. Disengagement, disidentification, or a change in professional aspirations. I put this red arrow here as a reminder that we can't change the stereotype threat, the microaggression in circle A, or the physiologic response that happens when that occurs. But we can be the red arrow and interact between B and C to prevent long-term consequences that might happen in the learning environment. The impact of microaggressions on our learners is strong. Individuals who perceive and experience racial microaggressions are more likely to have negative mental health symptoms such as depression, anxiety, a negative affect or a negative view of the world, and a lack of behavioral control. Social scientists describe this as racial battle fatigue as the framework of multiple physiological stressors from microaggressions. You may have heard death by 1,000 paper cuts. And in another study published in the Journal of General Internal Medicine, you see the microaggression score with an odds ratio of depression. And so what you see is that the higher the microaggression score, the fourth quartile there, the odds of depression and anxiety is 10 times the baseline amount. So that's the impact of that. So anticipate what is happening. Be the red arrow for your students. So think about being an ally there and reassuring, correcting misconceptions, creating teachable moments when you hear or see microaggressions happening in the wards. And this is a mixed method study that was published in collaboration, again, with the University of Colorado. Ty Loxweiser is here, Regina Richards, Amira Del Pino Jones, as well as investigators at UCSF. And what they did in this schematic is really talked about the power of the ally in interrupting negative internal dialogues and also responses in the environment. So how do we respond? So this is, many of you have heard about these Ds. I'm going to show them in a couple of different ways. Racism, discrimination, and microaggression response strategies include the Ds of displaying discomfort. So you can use your body language to show you notice something was wrong, scrunch up your face, fold your arms, look dissatisfied or upset. You can be direct and in the moment, firm, clear, and concise. What you said is not okay. I'm not happy with what you said. I'd like for you to stop. Sometimes we're not safe enough to do that. So then you can distract or shift the focus and change the subject. This is a good tool to use for people who are not in supervisory roles. So this is what I ask students to do, for example, if they're in a clinical setting or a learning environment where they feel like things are not going well, is to change the subject, maybe take the focus off of the person who is feeling the discrimination. Document what's happening, write it down, write an email. Sometimes we, in society, we think about videotaping and showing what's going on or recording something. You can also delegate, and this is something that our students often feel most powerful with, but speaking to someone else, documenting what happened, knowing the institutional policies, and asking someone else to follow up on it. And then digesting and circling back. So I love to circle back. It's never too late to do the right thing. You can say things like, I was thinking about what happened, it was wrong, and I'm checking in on you. Or I've had a chance to think about this and I want to circle back to the conversation that we had last week or that happened yesterday. This is an opportunity for you to bring things up when you maybe have had an opportunity to get some advice about how to handle the situation. Here is another example of the vignettes of the Upstander interventions that can happen. Again, showing direct, distract, document, delegate, digest, and reconnect. I like the particular examples here because they are ones that are both with a patient and then the others are in the operating room with responding to an attending, or it could be someplace in the wards. One of the particular examples I like is the delegating, where you elicit the support of other attendings, treating the patient and our residents or staff. So this is when a patient maybe uses a derogatory language when talking to the resident. Other folks around the room can step in. If it's in the operating room and the attending makes an offhanded comment, you can delegate or report the incident to, say, a chief resident or another attending or the residency program director, and then ask them to help you intervene as you feel vulnerable doing so alone, considering the power dynamic. Again, I think our students often feel this power dynamic, but I hear from a lot of faculty too that they're not sure exactly how to respond. Being direct is the most challenging. I think it's also the one that can be the most upsetting, but it is the most appropriate when something is egregious. I like the phrase in the red in the top box there that says, I assume it wasn't your intent, but I think that that's a bit insensitive. So it really, it allows the person to kind of save a little bit of face by saying, I'm sure you didn't mean to say this or for this to come out this way, but this is how it sounded. The last thing I think about is what institutions can do. So it's one thing to think about what we can do as individuals. All of us are reading, we're trying to be better, we're recognizing our own biases. And then I think about the program that you lead. What do you do for the program that you lead in your own LIC or with your own preceptors or in your own practice? You can think about that. And then taking it to another level, this is one where the school leadership needs to think about what do we do at the institutional level? And the hospitals are thinking about this too. What's our strategic approach in our mission, in our vision, in our policies? Do we have policies that say we don't allow these types of behavior? Do we have processes for promotion, for hiring, for award recognition, for appointments that can be improved at the institutional level so that we change the structures that lead to these differences? Do we collect data and monitor outcomes? Do we track our data of mistreatment based on race and ethnicity or gender or other protected identities? Do we provide faculty development and training sessions regularly about this? Do we state and measure inclusive outcomes in a transparent fashion? We would like to be known as a destination for people from diverse backgrounds. Do we articulate no tolerance policies? It was surprising to me once that the students actually reached out and said, you know, we don't have a policy that says that you can't say racial epithets in the school. I was like, well, I mean, I didn't know that we needed to have a policy written down about that. It seems pretty clear, but they were right. It wasn't written anywhere. So we put it into the teacher learning environment and made sure agreement and made sure that everybody knew that this was something that we would not stand at our institution. And then more importantly is probably and harder, more aspirational, is to cultivate an inclusive culture. And how do you do that? How do you make people still feel seen? I was reading an article in the New York Times this morning about the shift from the word inclusivity to the word belonging. It's not just important to say you're allowed to be here and we welcome you, but how do we actually make you part of the community and let everybody feel like they belong and have a seat at the table? So we all have implicit biases. Microaggressions are by definition subtle, but also destructive. Addressing microaggressions requires practice and courage. There are tools that we can employ to become allies and upstanders, and creating a brave and inclusive learning environment requires intentionality. You have to really think about doing it. So I have 2 slides of homework assignments. This is the first one. Where do you think that bias might sneak into your clinical environment or the curriculum? Where do the biases happen? Is it in the grading situation? Is it in the classroom? Is it in a particular part of the bedside? Is it in the operating room or the team room? Where do those things happen? And where then are there most likely areas where microaggressions, or as the former vice chancellor for diversity used to call micro disses, these little slights, where might they occur? In what settings could students, residents, or others feel pressure to, quote, fit in? And then consequently, if they didn't fit in, to have that lack of belonging. And what are some examples of language that you have read in evaluations, or that you might have actually written in evaluations, that invoke stereotypes around gender, race, sexual orientation, or religion? Or I'll add a concern that our students have too around their political thought and biases around that. What diversity exists in your decision-making committees, whether that's the assignment of students to preceptors, or it's in grading, or it's decisions about the curriculum? Do you have representation in those committees? And have you looked at the data in your area, whether that's research, the clinical, or the classroom through an equity lens? Have you looked, for example, at outcomes of vaccine uptake in your outpatient clinic, or diabetes control based on race and ethnicity, or surgical outcomes based on risk factors such as race and ethnicity in those situations? I'm gonna slide to this next slide here. I could have picked any image of a Black person in our society who had been impacted by bias and racial differences in police violence. But I picked Tatiana Jefferson. who died while she was playing video games with her nephew, whom she was babysitting. And the reason I picked her instead of Elijah McClain or Ahmaud Arbery or George Floyd, for example, is because Tatiana Jefferson wanted to be a medical student. And what I think about for her is what societal changes would have to take place in order for us to be a place where she could have become a medical student. And that includes things like educational access, things that you think are not within the purview of the medical school, right? Differences in access to clean water. I just saw an update on the Flint, Michigan story, for example, about access to clean water and health. Educational access. There was a paper published over the weekend also about differences in outcomes based on socioeconomic status and acceptance into medical school. Independently controlling for MCAT score and education and GPA, having lower socioeconomic status made you less likely to get accepted into medical school. So thinking about those structures is something that I say, this is our lane. This is something that we should be working on. So in this short period of time, with 5 minutes left, I hope we've been able to do a few things, clarify definitions of stereotype threat, but also most importantly, describe strategies to create a brave moment, and then reflect and strategize about fostering a culture of growth mindset where there might be discordance between learner and teacher views or identities. And these are my 2 next homework assignments, is for you to really think about how do you do that in the learning environments that you have. Create a place where people feel that they can be brave, where they may be able to challenge what's happening and to disrupt a microaggression that could be occurring, or even to ask questions about the care that we're providing to patients. And then to work together to create a growth mindset, even if we are different from our learner, where our views might be different or our identities could be different there. Stop sharing my screen and see if there are questions or comments from the group. It's really hard to talk to an audience with no people.
That was great, Shanta. Thank you.
Thanks. Questions or comments? All righty. Well, hopefully food for thought. The next time we do this, we can think about trying to practice. Maybe getting into a live group and practicing some cases where we use some of these strategies to actually practice being the upstander in the moment. All right, thanks for coming.